We will get started. We again are joined by Dr. Krug, who's joining us from all the way on the over in Boise, and who will be speaking to us today about EKGs. So, without further ado, I will turn it over to you.
Thank you very much. I'm excited to be here. Please put anything you like in the question and answer at any time. I'm happy to field that in real time or at the end. And then I thank you in advance for your participation with the audience response. That makes it much more fun. And I think much more high yield for you to put your nickel down. So let's see if we can learn some things today and get a few questions for you correct for you in the future. I have no financial disclosures. My one disclosure is that I'm a general internist, not a cardiologist. Many thanks to Dr. Zach Goldberger. He's a cardiologist in Madison, Wisconsin, who I've collaborated with on these slides, and ACP's Mixapp for allowing me to use some of their content, namely some of their ECGs. I took all of these ECGs and stems are based on delineated topics from the ABIM blueprint. So therefore, I hope they're high yield. There also may or may not be some questions on here that I may or may not have gotten on my boards. Okay, one sec here. 77-year-old patient from Oregon, lives in Oregon, has had 3 weeks of fatigue and dyspnea on exertion. No chest pain, no chest pressure. He has a history of COPD and hypertension and takes lisinopril and inhaled budesonide formoterol, which is an ICS-LABA combo. Labs, including TSH and exam, are normal. I'll show you the EKG, of course, is an EKG talk. What will you recommend? Stop their inhaler, order a Holter monitor, refer for pacemaker placement, cardioversion, or workup for other causes of fatigue. I'll go back to the stem in a moment. Okay, what do you guys think? And please give me feedback if I'm not spending enough time on the EKG. Thank you guys for participating, putting your nickel down in the poll. I appreciate it. Let's wait for a couple more. Okay, thanks all. So a mix of results. The best answer here is definitely C, pacemaker placement. And I didn't give you much in the stem, and that's by design. This is an EKG's talk. It's can you look at the EKG, figure out what's going on, distill the salient knowledge from the EKG to get the answer right? This is just a person with fatigue who lives in Oregon with normal labs. So let's get back to the EKG here. This patient has type 2 second degree AV block, aka not Wenckebach, aka the scary one. So if you see here on the bottom lead V1 rhythm strip, you see a P before the QRS, P before the QRS, P before the QRS, and then a P and no QRS, then a P and no QRS, then a P before the QRS, etc. So you can see that there's heart block going on. You suspect it's second degree heart block because it's not complete dissociation. And then you have to differentiate type 1 versus type 2 second degree heart block. Type 1 Wenckebach being generally more benign and type 2 being a higher risk block, close to third degree heart block, refer for pacemaker. So if you remember Wenckebach, you have prolongation of the PR interval before the drop beat. So you see in this top rhythm strip here, you've got a PR interval that's about maybe 5 small boxes. Then it becomes maybe 6 or 7 small boxes, and then you drop the beat, and that pattern repeats itself. You see in this bottom rhythm strip that there's the PR interval stays the same, and then all of a sudden a beat drops. So this is scarier, higher risk, higher degree block, more likely to progress to complete heart block. Generally, pacemaker is indicated. So here we go. So if you've got heart block, first you're going to fix a reversible cause before you go putting in a pacemaker. So if they're having heart block in the setting of ACS, like an MI, you're going to revascularize and hope that that fixes your heart block before you go putting in a pacemaker. Of course, if they've had beta blocker overdose or ingestion or calcium channel blocker overdose or injection, you're going to treat that with your glucagon or your calcium and with time before you go putting in a pacemaker. If they're hypothyroid, you're going to fix that. If they've got Lyme disease, then you're going to perhaps treat that and maybe get away without a pacemaker. Of course, this patient's from Oregon, so less likely. And then again, reiterating that Wenckebach generally knows pacemaker unless they're quite symptomatic. And then type 2 second degree heart block usually warrants a pacemaker unless there's an obvious reversible cause that you can fix in short time. The way I personally think about this is Wenckebach, he's a little slow, he's getting slower each beat and then sometimes even drops a beat, but you can rely on him. He's reliable. He's never going to leave you totally in the lurch. He's just slow. While his type 2 is erratic. It's a wild card. It's liable to drop a beat, give you a beat. It just has, it is not just slow, it is erratic. And erratic is scary, so you need a pacemaker. Okay, next question. 34-year-old with recurrent abrupt onset of palpitations. They last about 5 minutes each time and often subside when she kneels down. She has bipolar disorder and takes an atypical antipsychotic and a selective serotonin reuptake inhibitor. Her examination is unremarkable. Of course, I'll show you the EKG in a moment, and then I'd like you to recommend one of these options. One, stop the atypical antipsychotic, or A, I should say. B, stop the SSRI. C, refer for EP study and ablation. D, amiodarone, or E, atenolol. I'll go back to the stem in a moment. Okay, what do you guys think? So to be clear, this EKG is taken when the patient's feeling fine, not when the patient is having the palpitations. This is a resting EKG in between episodes of palpitations. Okay, great participation in this one. Thank you, guys. Okay, so 7% got the correct answer in this case, which is EP study and ablation, and I'll show you why. This patient has the delta wave, right? The Wolf-Parkinson-White delta wave. If you see here, they've got a wide QRS. The QRS should be 3 small boxes or smaller, 120 milliseconds. This patient's is more than that, maybe 3.5, 4 even. So they got a wide QRS, and in this case, the pattern of the wide QRS is that delta wave, where it has a slow upstroke and then shoots up. It's sinus rhythm. This person does not have a long QT, which is associated with antipsychotics. The QT interval looks normal here, so that's why that one's not correct. So the purpose of this EKG is recognize the delta wave of Wolf-Parkinson-White, and then you have to have the knowledge that Wolf-Parkinson-White syndrome, which is Wolf-Parkinson-White pattern on EKG, delta wave plus associated palpitations, tachyarrhythmia, generally warrants EP study and ablation. So I know a previous speaker touched on this yesterday, so I think that actually highlights how important this is to the boards. And I don't think it's a waste of time at all to go through it again. It's because I think this is crucial. So the Wolf-Parkinson-White, Wolf-Parkinson-White pattern. What's happening here? There's a hole in the heart, an accessory pathway. So when the SA node starts to depolarize the atrial myocardium, and then usually it just hits the AV node, goes down the His-Purkinje, and that's what depolarizes the ventricular myocardium. Of course, there's a lag in the AV node. So if there's SA node electrical conduction reaching this accessory pathway, it's going to start depolarizing lateral ventricular myocardium before the His-Purkinje kicks in because of that AV nodal delay. So therefore, you get this slow start to depolarization of the ventricles before the His-Purkinje kicks in and gives you that dramatic upslope. So you're going to get a short PR interval with a wide QRS with that characteristic delta wave pattern. And when are you looking for this? In the setting of recurrent tachyarrhythmias, namely AVNRT. So that's when you're looking for it. So this is the exact stem that you should be looking for a delta wave. Whoa, a younger person's having recurrent palpitations. Look for Wolf-Parkinson-White because the treatment's going to be distinct. So what's happening in sinus rhythm? It's going down. The sinoatrial node is firing off. It's going down to the AV node where there's a lag. So then it starts to depolarizing the ventricular myocardium first, gets the delta wave, then it gets through the His-Purkinje and shoots up, right? Then what you can have is a tachyarrhythmia where you get a spinning reentrant loop coming up the accessory pathway and down the AV node, something like 180 to 200 times a minute, just flinging around in this, and you get a narrow complex tachycardia arrhythmia. Rarely it can go the other direction, antidrome. It can cause a wide complex tachycardia where it's coming up the AV node, and then who knew it could go up? I didn't know that. But where it can go up the AV node and then down the accessory pathway and cause a wide complex tachycardia. So of course you're not going to treat this wide complex tachycardia with adenosine. You're going to use procainamide or something like this. And just like the speaker yesterday showed you, if you've got AFib with a delta wave, then you're going to use procainamide, not adenosine. Okay, if you just have this pattern on a random EKG, usually no treatment indicated. However, if you have the delta wave, you have an accessory pathway, and you're having tachyarrhythmias, then EP study and ablation is the first line therapy. First line. The medications are only used if you're not able to undergo ablation. And why is that? Because we showed this here, right? So this is a simple EP study. They just go right over here to the side of the heart, not as much stuff around it. Cauterize that thing off, block the accessory pathway, and that person's good to go. Hopefully we'll never have that again, rather than, a lifetime of flecainide or propafenone or something like this. So treatment of choice for Wolf-Parkinson-White syndrome with tachyarrhythmias is EP study and ablation. Next case. Great question. Can we trust the boards on patient's location origin? I think that's a great question. I think that if they give you an origin, they're probably leading you to something. Of course, there could be a red herring. In this case, it didn't matter as much, right? Like there wasn't an option to check for Lyme disease, right? If there was an option for check for Lyme disease, then we could quibble, or I guess it's the previous one. But good question. It's vagal maneuver. Yep. Yeah. So if you've got a tachyarrhythmia that goes through the AV node, whether it's AVNRT or otherwise, a vagal maneuver will help break that. So this patient was kneeling down, which promotes some vagal tone often, and that was prompting that. Of course, that's not classic vagal, right? Classic vagal is bear down, but kneeling down can sometimes do it also. Thank you, Dr. Wren. Okay, next case. 62-year-old presents with sharp, severe central chest pain. She's treated with aspirin 325, a statin, morphine, nitroglycerin, with improvement in pain from 8 out of 10 down to 4 out of 10, but not resolution of the pain. I'll show you the EKG. What will you recommend? Cardiac cath, aka percutaneous coronary intervention, left heart cath. B, coronary artery bypass grafting, CABG. C, heparin drip. D, NSAIDs. E, ranolazine. What do you guys think? Keep those answers coming. You guys are doing great. Okay, so only 1 out of 10 got the best answer in this one. The best answer here is D, NSAIDs. And like you're thinking in real life, what? But I'm not sure what's going on. I'm going to involve cardiology. Yeah, you should, but in the boards, there's no cardiology. It's all you. And the best answer here is NSAIDs, and I'll show you why. This person has pericarditis. So if you look back at this ECG, so yeah, there's ST depression down inferiorly, right? 2, 3, and AVF. You've got ST elevations there. But also there's ST depressions way laterally, right? V5, V6. Septally there are, so they've got inferior septal and lateral ST elevation, so basically diffuse ST elevations. And then also geeking out a little bit more, this person has pretty clear PR depression prior to the ST elevations. And finally, they have concave rather than convex ST elevations, right? All those are suggestive of pericarditis more so than ACS. Okay, so remember, you've got to triangulate and tie break using your coronary anatomy when looking at signs of ischemia on EKG. So I remember the acronym IC all leads. So I start here in the bottom left pocket. That's the inferior leads, 2, 3, and AVF. C is septal, V1, V2. All is anterior, V3, V4, and lateral is V5, V6. And certainly you've all seen some overlap between septal and anterior and lateral, right? This person has an anteroseptal MI. This person has an anterolateral MI. But there shouldn't be overlap between all of them. There shouldn't be inferoseptal anterior lateral MI. That's too many vascular distributions. So that's suggestive of pericarditis, especially if you have the other features. So recognize acute pericarditis. This is going to come up on your boards. So ST elevation in multiple coronary distributions, PR depression, especially in lead 2, and then concave rather than convex ST elevation. And then the treatment of choice for pericarditis is NSAIDs if they can, unless they have a contraindication. So if I gave you some of the, maybe the board is going to be kind to you and give you some of these other features, right? Pain is improved with sitting up and leaning forward and worse supine based on how much pressure is on that pericardium. If they give you a friction rub, a multi-component friction rub on the physical exam of the patient, they're basically telling you it's pericarditis. Common causes, uremia, so patients with end-stage renal disease, or rarely with severe acute kidney injury. Idiopathic or viral, if it's part of a viral syndrome. Chest irradiation in recently or in the distant past. And recent cardiac surgery, so-called Dressler syndrome. So how do you work this up? Usually we do get an echocardiogram to look for a concurrent effusion to make sure that that doesn't need to be followed over time. You're going to check a troponin to see if they have myopericarditis, because those things are close together, the pericardium and the myocardium. And again, the treatment of choice is NSAIDs, usually with colchicine as an adjunct is first line. Glucocorticoids are only if they can't have NSAIDs or if they have an autoimmune mediated pericarditis, right? They have lupus and pericarditis. Okay, generally prednisone will be the treatment of choice there. Okay, next case. 41-year-old patient admitted to the hospital. Past medical history, chronic pain. Home medications, methadone, turmeric, diclofenac gel. This patient had a completely normal EKG 14 months prior. You just have to trust me on that. New studies, EKG today that I'll show you in a moment. What happened in the hospital that led to this patient's EKG abnormality? A, they got Haldol. B, they got promethazine. C, they got doxycycline. D, they got hyperkalemic. E, they got hypercalcemic. I'll go back to the stem. Very good. Very impressive. Very impressive. The right answer here is A. Usually when I do this talk, a minority get that correct. So very good job. Strong work. But let's go through it real quick. And then I'll point out the PR depression on the previous case. Oops, sorry. Also, sorry, I'm a little bit playing games, right? The first few questions had like a medication effect as the culprit, and then it wasn't it, and now it is the medication culprit is the culprit. So I sorry, not sorry on that. I think meds are a common cause of EKG abnormalities, as are electrolyte derangements. But okay, here, let's walk through this one. So this person has long QT syndrome. You look at this where this T wave ends. It ends more than half the distance between the QRS complexes. Therefore, it's a QTC longer than 500. Therefore, it's really problematic. And this person is a setup for that. I'll show you why. So the thing you need to do is recognize long QT syndrome. Yes, in real life, we might look at the top, when it says QTC 520 or whatever it is. I agree. I also look at that. But I believe on the boards, they're also going to want make sure that you corroborate that with looking at the EKG itself. So the heuristic is that if the T wave ends more than half the distance between the QRS complexes, the R to R interval, then it is longer than 500, which we all know is significant and worrisome for development of torsades, especially with another hit. Common causes of acquired long QT syndrome, antipsychotics, especially IV haloperidol, classically, though that's a little bit under question lately. TCAs can do it alongside their widening of the QRS complex. Fluoroquinolones, macrolides, azoles. Some antiarrhythmics can do it. So even though they're actually reducing your risk of arrhythmia, they are prolonging the QTC. The classic one is amiodarone. Methadone and buprenorphine are classic prolongers of the QT, and then hypokalemia can do it. Remember, hyperkalemia is peak T's and wide QRS, even prolonging to that horrific looking sinusoidal pattern. So that's hyperkalemia. Hypokalemia can elongate the QT. And hypercalcemia actually shortens the QT. Hypocalcemia longens the QT. Also, you didn't see doxycycline on here. The tetracyclines don't commonly do it. And then of the antiemetics, ondansetron is the biggest actor, and promethazine, which is in the stem, actually doesn't cause it that much, so a little bit tricky. But so the antipsychotics, bad actors, quinolones, azoles, macrolides, methadone. Okay. Now, before we do this, let's actually go back. I want to point out the the PR depression in this EKG. So if you see, where can you see it the best? Let's see 2. Look at lead 2 on this EKG on the left-hand side. You see the T wave, then you see the baseline, then you see the P wave, and then, whoa, this drops down, right? You see that between the P wave and the QRS in lead 2, you see it drop down, and that's PR depression. And that's classic for pericarditis. Hopefully you guys can see that. Lead 2. That's classically where it's best seen, and especially in this EKG is where it's best seen. Okay. All right. Remember, you've got the patient with the long QT syndrome. This same patient who had long QT syndrome from their methadone plus Haldol develops the following abnormality on telemetry. She feels off. She feels lightheaded. She's oriented and lucid. You're going to put pads on and you're going to cardiovert or maybe even pace or something like that. What else would you administer to this patient? And you can open the poll now. Calcium, amiodarone, atropine, magnesium, or epinephrine. What are you going to administer in addition to getting some pads ready for probably cardioversion. Man, you guys are all over this one. Okay, yeah, it's magnesium. So this telemetry abnormality is torsade de pointe, which is ventricular fibrillation of widening and narrowing amplitude, right? This is torsade de pointe. So you're going to cardiovert this, and you're going to use IV magnesium as an adjunct. Amiodarone is also fine. Wouldn't hurt, maybe would help, especially if the shock doesn't work, but magnesium classic for torsades. Very good. You guys nailed that one. Okay. VTAC, VFib, usually cardioversion or defibrillation. So synchronized cardioversion for VTAC, defibrillation for VFib. You can use IV magnesium sulfate for torsades from long QT, amiodarone for non-torsades, VTAC or VFib. Next case. 73-year-old presents with 3 days of palpitations and marked dyspnea with exertion, way worse than normal. No history of arrhythmia or heart disease. Heart rate is 105, blood pressure is 108/55. He's uncomfortable, but he's lucid and conversational. Chemistry panel and TSH are normal. Transthoracic echocardiogram shows diastolic dysfunction and normal atrial size. I'll show you the EKG in a moment. What will you recommend? Immediate cardioversion, transesophageal echocardiogram, then cardioversion, adenosine, EP study and ablation, or vagal maneuvers. Okay, back to the stem. What do you guys think? Okay, thanks for your answers. Yep, the majority got it right. B is the best answer here, transesophageal echocardiogram, then cardioversion. A is a little bit risky. E, vagal maneuvers won't really break AFib. Those will break AVRT, AVNRT. Okay, so this EKG has atrial fibrillation, shows atrial fibrillation, right? Irregularly irregular, where there's no rhyme or reason between the spacing between the QRS complexes. There's no reliable P waves. In fact, there may be this fibrillating baseline, which is the case in this one. So irregularly irregular, you're thinking AFib or maybe some kind of heart block or bigeminy or something like that. But most often AFib, especially if it's narrow complex. I mean, good. So cardioversion and AFib. If it's critical, right? If you think that if they're hypotensive, they're having myocardial ischemia, they literally can't breathe, and you think it's related to the AFib, then you bite the bullet, you cardiovert, and you deal with the stroke risk. However, by cardioverting someone who's not been an anticoagulation, there's a risk that you're going to dislodge an existing atrial thrombus and precipitate a stroke or systemic embolism. So that's the risk there. So much more often, the middle option, this is super rare. If somehow you know that the patient's only been in AFib for less than 48 hours, then you can just cardiovert because it hasn't been long enough to create a thrombus in the atrium. This almost never happens. Maybe if they had like an implanted loop recorder or an Apple Watch that you trust or something like this, but most of the time we're just like, we're not sure if it's been 48 hours or not, so we're not going to do that middle option. But theoretically, you can do that. I've literally never seen that happen. And then the bottom one is the by far the most common sequence of events. If they're not dying in front of you from their AFib, and they've had AFib for at least 48 hours or you don't know how long, then either you're going to do a transesophageal echocardiogram to look for thrombus right next to the atria, because you can do that transesophageally. You can look at the atria better than tranthoracically. And if you don't see a thrombus, then you can cardiovert. Or you're going to anticoagulate for at least 3 weeks prior to the cardioversion to melt that clot, and then you're going to do the cardioversion. So usually it's actually the 3 week one. So this bottom one is usually what happens. Oh, you got new AFib? Oh, we want to try and cardiovert you. Cool. Take this apixaban for 3 weeks and then come back and we'll cardiovert you. If they're really serious, like this patient, he's markedly short of breath, miserable. Okay, we'll do a TEE first and then cardiovert you. And actually, even in that case, they would probably have him swallow an apixaban or squirt him with some heparin right before it just to get a little bit of anticoagulation on board. Okay. I'm going to show you another EKG. Which of the following conditions is this EKG consistent with in the right clinical setting? A, Wellen syndrome. B, Brugada syndrome. C, pericarditis. D, hypokalemia. E, hyperkalemia. Okay, what do you guys think? Okay, bravo. Yeah, the right answer is B, Brugada. Well done. Very impressive. This is a high level thing, but this is tested on the ABIM boards. I can tell you that with certainty. Okay, Brugada syndrome. So I'll go back to the picture of it, but this is a sodium channel gene mutation. It usually presents in younger people. The EKG changes may be transient and only come out when they're sick, like if they have a fever or they just start on new medicines or their electrolytes are out of whack. But if it comes and goes, it's there. You know, don't just say, it only happened when they had a fever. Ooh, that's classic for Brugada syndrome. So you got to take it seriously if you ever see this, even if they're sick and there are reasons to be off. If they have this EKG pattern and they have themselves had VF or VT, obviously, but even if they've had a family history of sudden cardiac death, syncope, or inducible VTAC or VFib, then they get an ICD. So this pattern is so pathognomonic for this problem that any whiff of trouble, even in family members, will lead to these patients getting an ICD because it's so lethal. So how are you going to recognize this? Prominent ST elevations in V1 and V3 that is often straight or concave with a subsequent inverted T wave. So you see how crazy this is, right? This is a crazy QRS complex with major weird looking ST elevations with a big inverted T wave after it. So that's the Brugada syndrome. Wellen's pattern, which a couple of you chose, so this is impending LAD occlusion. So this is, you sometimes see this in like an NSTEMI, right? Because it's not a STEMI, but it's a high risk NSTEMI because it's the LAD. So that is deep symmetric T-wave inversions in the precordial leads, V1 to V4, and it's pretty symmetric. So you see how deep these T waves are? Whoop, 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 whoop. You know, this is not just like, oh, flattening or a little bit of inversion. This is deep inversion of those T waves. And Wellen's pattern suggests impending LAD occlusion. Okay. Next Next case, 71-year-old with 2 hours of substernal chest pressure and diaphoresis. Prior EKG from 2 years ago was normal. You just have to trust me on that. New EKG, I'll show you. What's the most appropriate next step? Again, substernal chest pressure, diaphoresis. Emergent cardiac cath, medical management of ACS with probably a cath within 24 hours, nuclear medicine stress test, hemodialysis, or NSAIDs and colchicine. Okay, I'll go back to the stem. What do you guys think? What's the most appropriate next step for this patient with substernal chest pressure and diaphoresis in that EKG? Okay, thank you guys for your participation. Yeah, great job. The best answer here is emergent cardiac cath. I see an answer for medical management and one for D. I'll go through why those are less good. So what does this patient have? A left bundle branch block, right? So they have a wide QRS, and then they have that kind of double humped mountain looking R wave in leads V5 and V6. You can see that there. And so the knowledge pearl is that a new left bundle branch block is the same thing as ST elevation in the right setting. So that's why the right answer here is emergent cardiac cath and not medical management. It's because it's a new left bundle branch equals STEMI. The reason it's not hemodialysis, even though hyperkalemia can cause widening of the QRS and peak Ts, and maybe these are a little bit peaked, it shouldn't cause chest pain. Like this person didn't come in with an arrhythmia, or missing dialysis. This person came in with chest pain and chest pressure. They've got a new left bundle branch block. They need a cath. Okay, so left bundle branch block, wide QRS, again, greater than 3 small boxes or 120 milliseconds, broad Slaughter notch R wave in V5, V6, and then a concurrent broad S wave in V1, or reciprocal, I should say. Right bundle branch block, you remember, is RS, R prime in leads usually V1 or V2, again with a wide QRS. And again, the knowledge pearl is that a new left bundle branch block in a patient with ACS is a STEMI equivalent, right to the cath lab. So it's just like as if they had tombstones in a vascular distribution. Now, how do you know whether the bundle branch block is new? You often don't. So if someone comes in, they have ACS, their EKG shows the left bundle branch block, there's always this frantic scramble to try and find old EKGs. And if you find an old EKG and they already have the left bundle, you say, okay, maybe this is an NSTEMI. If you find an old EKG and they did not have a left bundle, you have to assume that that one in front of you is brand new, and that's a STEMI equivalent. They go right to the cath lab. Okay. The guidelines change. The new left bundle branch is no longer a STEMI equivalent. Yeah, you can definitely look at the modifier Scarboza. So this is that last part I definitely agree with. Cardiologists may be able to tell whether your new left bundle meets criteria for a STEMI or not. They can like squint at it and see if it looks different. So that is correct. But I think for the internists and your boards, a new left bundle equals freak out. And if a cardiologist looks at it and Scarbozas it and can tell the difference, then that's fine. But I would suggest that you proceed with a STEMI type of path if it's a new left bundle. I don't think that they're going to test you on Scarboza criteria for the IM boards. Great point, Andrew. Great knowledge. Okay. 27-year-old man presents to the ED with 2 hours of palpitations. He's had this several times in the past, but previously it had resolved on its own after 5 to 10 minutes. No past medical history. His father had an MI at age 53. His pulse is 200. His blood pressure is 124/75. He's anxious. On exam, he's tachycardic. It's regular. There's no murmur. You try a carotid sinus massage after listening and there's no effect. We'll show you the EKG. What's the next step in management? Synchronized cardioversion, A. Unsynchronized cardioversion, B. Amiodarone, C. Adenosine, D. Okay, what do you guys think? Good. Yep, best answer here is adenosine. So this is an SVT, specifically PSVT. So how are you going to diagnose this? Fast, right? AFib, A flutter, that's usually, around 100, tops off around 150 or so, something slightly faster. SVT is often 180, 200. So even just the speed, narrow complex regularity, you're thinking SVT. Sudden onset termination and sudden termination, often younger people, but not always. Good. So SVT, how is that working? So it's a reentrant loop. We already talked about accessory pathway, right? So that's when it's spinning up the accessory pathway, down the AV node. But then also there's AVNRT, which is the accessory pathway is entirely contained within the AV node itself. 180 to 200 an hour. And then sometimes you can get an ectopic focus in the atria causing atrial tachycardia as well. So the treatment for all these can be adenosine. Again, like the speaker told you yesterday, if they have an accessory pathway and then they have a fib, that's when you got to go with procainamide. But if they just have the narrow complex non-AFib accessory pathway associated tachycardia of SVT, you can treat with adenosine. Okay, so this person had AVNRT, which again is the spinning loop was entirely housed within the AV node, and you can tease this out if you want to, even though it's not going to change your management by seeing a retrograde P wave next to the QRS, and that's because as it's spinning, it's shooting depolarization up to the atria as well as down through the His-Purkinje system. So you can see an inverted P wave and point you to AVNRT, though again, the treatment is generally the same. Okay, how are you going to abort this? You're going to try vagal maneuvers first, carotid massage or Valsalva. This person, you tried the carotid massage, it didn't work. And then you're going to go to adenosine, you're going to go 6 IV. And then if that doesn't work, you're going to go 12 IV. Long term, you can do nothing. If it doesn't happen often, you can do ablation. Again, if it's accessory pathway, ablation is treatment of choice. If it's AVNRT in the AV nodal or ectopic, then it's not as clear. Or you can suppress with a beta blocker or calcium channel blocker, depending on the circumstances. Okay, we talked about that. The zebra is antidromic AVRT, so wide complex. So if you've got wide complex tachycardia from any reason, you're not generally going to use adenosine, right? You're going to use medicines for wide complex tachycardia like amiodarone or what have you. And that case also holds if you've got Wolf-Parkinson-White or antidromic AVRT with wide complex tachycardia. Okay. 76-year-old with COPD presents to the ER with 5 days of intermittent palpitations. She has no history of heart arrhythmia. Blood pressure is 135/75. What would you recommend for treatment of these palpitations? Cardioversion, adenosine, diltiazem, amiodarone, or levoalbuterol? Okay, what do you guys think? Okay, thank you guys for answering. A mix of answers here. So this patient has atrial flutter. So how do you know this? Well, the first, for it's regular, it's narrow complex. So it's not a fib because that would be irregular, right? It's not the speed of SVT 180 to 200, but maybe it's a slower SVT, fair enough. But then you see here that the rate is almost exactly 150. That's suggestive of atrial flutter. And then if you look down here at lead 2, man, that does look like a saw, right? Like I could saw something with that lead 2, right? If I put some wood underneath your computer monitor, you could saw the heck out of that. That's the sawtooth pattern. So this is atrial flutter. So how do you treat atrial flutter? You could cardiovert it, but it's been a while, so you're probably going to want to TEE first. So generally, you're just going to slow it down. Okay, it is usually regular, rarely irregular. I think in your boards it's going to be regular. The rate is often 150 a minute, so think about a flutter, especially if that's the rate, and then the sawtooth pattern. It's also a spinning reentrant loop, but in this case, it's around the tricuspid annulus. Short term, you're going to just rate control it. So the best answer here was diltiazem, or beta blockers or digoxin, all the same for flutter. And then long-term management is typically ablation because for flutter, you can ablate it more easily, right? It's this ring. It's a spinning reentrant loop around the tricuspid annulus. So if you just buzz that, beep, cut off that ring, you've solved the arrhythmia. Versus AFib, the ablation is a little more complicated, right? There can be multiple foci, so you're basically buzzing, often somewhat blindly around the pulmonary tracts. So it's a little bit trickier. So for flutter, typically ablation, spinning reentrant loop, rate of 150. Okay, so fear not the narrow complex tachycardias. You can have sinus tachycardia, P before every QRS. You can have the SVTs, regular, very fast, usually 180 to 200, either atrial tachycardia, which is an external foci, AVNRT, which is the concealed loop within the AV node, or AVRT, which is accessory pathway. You can have atrial flutter, sawtooth pattern, rate around 150 usually, or a multiple of that, 75, 100, 150. Sorry, not a multiple of that. Atrial flutter spins at 300 per minute. So then you have to have a multiple of that. Is it going to catch it every time? No, because you can't go 300. Okay, every 2 spins. Okay, yeah, then the rate's going to be 150. Every 3 spins, okay, the rate's going to be 100. Every 4 spins, the rate's going to be 75. So if you have one of those classic numbers, then that's more likely to be fluttered. I think they're going to give you 150. And then atrial fibrillation, narrow complex, irregularly irregular. Next, 82-year-old man had an episode of syncope while walking uphill. He has hypertension and takes chlorthalidone and amlodipine. His pulse is 65, blood pressure is 106 over 50. He's oriented and he's actually pretty talkative. He has a 3 out of 6 systolic murmur at the right upper sternal border. I'll show you the EKG. What's the most likely cause of his syncope? Aortic stenosis, hypovolemia from his chlorthalidone, heart block, or vasovagal? Okay, what do you guys think? What's the best answer here? Wow, very good. I don't think I've ever seen 100% get this right. Well, very well done. Usually people just can't get past that murmur. But you're right. You looked at the EKG, and that's a great read. This person has complete heart block, third degree heart block. So if you look at this rhythm strip at the bottom, if you see these kind of triangles going downward, those are the P waves. So you see that the P waves are marching through regularly, but that the QRSs are marching through also regularly, but not lined up with the P waves, right? So there's complete dissociation between the P waves and the QRS complexes. That is the hallmark of complete heart block. Also, I think this ECG illustrates an important thing to keep in mind. Complete heart block often looks regular, right? This is regular. These QRSs are happening regularly, right? It doesn't have to be disorganized. So type second degree heart block is often irregular because of dropped beats, and then it becomes regular in third degree heart block because of escape pathways, right? So it's just, you have to recognize that there's dissociation between the P's and the QRS. Fast rate for complete heart block, yeah. The escape pathway is usually in the 50s. In this case, it's about 60, so maybe a little bit fast. But again, I think that that's helpful because otherwise everyone gets it, right? If the rate is 30, everyone's like, oh, it's probably heart block. I don't think they're going to give you a rate of 30. That's too much of a gift. They're going to give you a rate in the 50s or 60, and they're going to want you to see that the P's and the QRSs are dissociated because that's crucial to managing this patient. Great question, Jay. Thank you, or comment. Great comment. Okay, you guys nailed that. So you see here, the P's are marching through and the QRSs are marching through, and they actually both are regular. The P's are happening regular, the QRSs are happening regularly. They're just not lined up. Okay, so summary for AV conduction disturbances. First degree heart block, more than one large box or five small boxes between the start of the P and then the start of the QRS. Wenke-Bach, or second degree Mobitz 1, is the prolongation of the PR interval before the drop beat. Just a little lazy, but ultimately will get the job done. Second degree type 2 heart block is higher risk. That's where there's no prolongation between the PR interval, just the drop beats. Wild card usually needs a pacer. And then complete heart block looks pretty regular actually, but when you look more closely, there's dissociation between the P waves and the QRSs. You guys nailed that. Very, very good job on that. I'm very impressed. So permanent pacers, if they've got bradycardia, you can't reverse it and it's causing symptoms, okay. Usually with Mobitz 2 second degree heart block, they're going to get a pacemaker. And usually third degree heart block, they're going to get a pacemaker. Unless there's some obvious reversible causes, beta blocker overdose, hypothyroid, Lyme, carditis, etc. With a STEMI, you can get heart blocks, and usually those will improve with vascularization and time, but if not, then they're going to get a pacemaker. Okay. I don't know what that was. 53-year-old brought in to the ED by medics with weakness and confusion. I'll show you the EKG in a moment. Are you going to activate the cath lab, give him insulin and glucose, give him magnesium, or give him calcium? Okay. What do you guys think? Okay. 50% got the right answer. The best answer here is definitely E, IV calcium. So unlike that, this is hyperkalemia. So unlike that other STEM that was a setup for a STEMI type question, this is how someone might present with severe hyperkalemia, right? Might have missed dialysis, has uremia, has some kind of ingestion otherwise. So this is a classic EKG for advanced hyperkalemia, right? Peaked T waves very clearly. If you sat on these, it would hurt you. It would hurt your rear end. So that's a peak T wave. And then wide QRS also, right? The QRS longer than three small boxes is a wide QRS. that can happen with advanced hyperkalemia. So this is a classic EKG for hyperkalemia. And so, of course, if you've got EKG changes with hyperkalemia, especially QRS widening, you're going to do calcium first to stabilize the membrane before you go to your insulin and glucose and perhaps sodium bicarbonate, et cetera. So here's what you got: hyperkalemia, mild to moderate, you're going to get peaked T waves with a normal duration QRS. Moderate to severe, you're going to have the peak Ts with a widened QRS. Very severe, you're going to have like wide, just horrifically wide sinusoidal looking or VTAC looking QRS complexes. Yeah, again, what I said before. EKG abnormalities are present, you're going to give IV calcium. If not, you maybe don't need to give it unless it's severe, and then you're going to give insulin and glucose, and then you're going to get rid of the calcium, the potassium with dialysis or with a binder. Okay, let's stop there. I think there's one or two more cases in the slide deck. If you're interested, you can review it on your own, but I want to make sure I finish before the next speaker, and I'm happy to take any questions. Thank you guys for your participation. That was fun.
Thank you so much. Fantastic as usual. And appreciate you tackling those questions in flow.